السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on heart sounds and murmurs in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for this learning activity, and here we have the recommended learning resources for this lecture. In the two lectures on cardiac cycle, we very briefly described the causes and the timings of the heart sounds in the cardiac cycle. In this lecture, we shall describe the causes and the timings again of the normal heart sounds and the abnormal heart sounds, which are called the heart murmurs. The heart sounds are detected over the anterior chest wall by auscultation of the heart using the stethoscope or by phonocardiography. The phonocardiogram is a graphic recording of the heart sounds using a machine which is known as the phonocardiogram machine. This machine picks up the sonic vibrations, the sound vibrations which are produced in the heart using a highly sensitive microphone. These sonic or sound vibrations are then converted into electrical signals with the use of a transducer and fed into a galvanometer where they are recorded on a paper, or they can be recorded on a monitor or on the screen of a computer. This is a figure which shows phonocardiography of the heart sounds. Normally, only the first and the second heart sounds are heard with the stethoscope. S3 and S4 are detected by phonocardiography, and also S1 and S2, as we mentioned in the previous slide. Occasionally, S4 is heard with the stethoscope in normal individuals, and S3 is often heard about 1/3 of the way through diastole in children and many normal young individuals. When we auscultate the heart, we place the stethoscope on standard positions on the anterior chest wall. This is because generally the sounds which are produced by the closure of each cardiac valve is best heard over a particular region of the anterior chest wall. For example, closure of the pulmonary valve is best heard at the pulmonary area, which extends from the second to the third left intercostal space near the sternum. Closure of the aortic valve is best heard at the aortic area, which extends from the second to the third right intercostal spaces near the sternum. The mitral area is where we place the stethoscope to hear best closure of the mitral valve, and this is at the apex. It is at the fifth left intercostal space crossing the midclavicular line, or it is about 9 centimeters or 2.5 to 3 inches from the left border of the sternum. The tricuspid area is at the left lower sternal border. However, it is very important to note that in general, both the first and the second heart sounds which are the sounds which we normally hear using the stethoscope, the first and the second heart sounds can be heard at all auscultatory areas. Here again in this figure we have the standard positions of stethoscope placement for cardiac auscultation. This is the aortic area, this is the pulmonary area, this is the mitral area, and this is the tricuspid area. These are the anatomical positions of the valves. So these anatomical positions of the valves, they are different from the standard positions of stethoscope placement for cardiac auscultation. The first heart sound is caused by the vibrations which are set up by the sudden closure of the mitral and the tricuspid valves at the beginning of ventricular systole. So the first heart sound is heard with the stethoscope at the beginning of the isometric contraction phase of the cardiac cycle, and also detected by phonocardiography. This is a phonocardiographic recording of the heart sounds. The first heart sound is detected by phonocardiography at the beginning of ventricular systole. It is a slightly prolonged low lobe sound, so it sounds like the word lobe, and it has a duration of approximately 0.15 of a second and a frequency of about 25 to 45 hertz. At slow heart rates, the first heart sound becomes soft. This is because with slow heart rates, the ventricles would have longer time to get filled with blood, and the leaflets of the atrioventricular valves, the mitral and the tricuspid valves, float together before systole, and hence when they close at the beginning of ventricular systole, the sound which their closure produces becomes softer than the case with the normal heart rate. The second heart sound is caused by the vibrations which are set up as a result of closure of the semilunar valves, the aortic and the pulmonary valves. And this happens just after the end of ventricular systole. It is here where we have the end of ventricular systole. So S2 is heard just after the end of ventricular systole and at the beginning of the isometric relaxation phase of ventricular diastole. It is a shorter sound than S1, but it is high-pitched sound, which sounds like the word dub. So when we hear the first and the second heart sounds with the stethoscope, these two sounds will hear like lop, dop, lop, dop. S2 has got a duration of approximately 0.12 of a second, and its frequency is about 15 hertz. In subjects who have systemic arterial hypertension or pulmonary arterial hypertension, where the diastolic arterial pressure in the aorta or the diastolic pulmonary pressure is elevated, S2 becomes louder and sharper than normal. This is because the elevated diastolic pressure in the aorta or in the pulmonary artery causes the respective valve to shut briskly at the end of ventricular systole and at the beginning again of the isometric relaxation phase of diastole. During inspiration, the aortic valve closes before the pulmonary valve, This reduplicates the second heart sound, resulting in physiological splitting of the second heart sound. So here we have, this is the aortic component of the second heart sound, and this is the pulmonary component of the second heart sound during inspiration. So in normal subjects, during inspiration, the first and the second heart sounds would hear like lob the dub, lob the dub. Lob is the first heart sound, and the dub the first D. This is the aortic component of the second heart sound, and dub, this is the pulmonary component of the second heart sound. The hemodynamic basis of this normal physiological splitting of the second heart sound is because during inspiration there is increased venous return to the right side of the heart. So the right ventricle gets filled with more blood during inspiration, and its systole is thus slightly prolonged when the right ventricle begins to contract. Thus, because there is increased venous return to the right ventricle during inspiration, the right ventricle has more blood than usual to eject during systole, and it thus takes more time for the right ventricle to eject the stroke volume, and as a result of that, the pulmonary valve closes after the aortic valve, or in other words, the aortic valve closes before the pulmonary valve. Normally, no splitting of the second heart sound is heard with the stethoscope during expiration, or is seen on phonocardiography during expiration. So this is the physiological, the normal splitting of the second heart sound, which is heard in normal individuals during inspiration. We might have abnormal splitting of the second heart sound in the form of fixed splitting of the second heart sound, where the second heart sound is split both during expiration as well as during inspiration, with the aortic valve closing before the pulmonary valve. So not only the second heart sound splits during inspiration, but when there is fixed splitting of the S2, it also splits during expiration. And this is heard in cases of atrial septal defect. We might have other abnormal splittings of the second heart sound. For example, we might have wide splitting of the second heart sound, and this happens in cases of right bundle branch block. So when there is right bundle branch block, the depolarization of the right ventricle will be delayed, and the subsequent contraction which follows depolarization of the right ventricle would be also delayed, and hence it would take even longer time for the pulmonary valve to close. So in cases where we have wide splitting of S2, as in right bundle branch block, the splitting of the second heart sound is heard during inspiration, and the split may also be heard and seen during expiration. So here we have, this is the wide splitting of the second heart sound during inspiration, and this is the splitting of the second heart sound which is heard also during expiration, in cases of right bundle branch block. Remember the right bundle branch, this is a branch of the AV bundle, the bundle of His, and this is the bundle which is responsible for the depolarization of the right ventricle. Wide splitting of S2 is also seen and heard in cases of mitral regurgitation or ventricular septal defect, because in these cases the aortic valve closes earlier than normal, resulting in wide splitting of S2. So here we have a case of mitral regurgitation. So during inspiration, this is the closure, this is the aortic component of S2. So the aortic valve closes earlier than normal, resulting into wide splitting of S2 during inspiration, and the splitting of S2 is also heard during expiration. We might even have paradoxical splitting or reverse splitting of S2. Reversed or paradoxical splitting of S2 is typically heard during expiration, with the pulmonary valve closing before the aortic valve. No splitting is heard during inspiration when there is paradoxical splitting or reverse splitting of the second heart sound. So in the reversed splitting or in the paradoxical splitting of heart sound, the pulmonary valve closes before the aortic valve, and the splitting is heard during expiration. So this is totally the opposite of the physiological splitting of the second heart sound. Paradoxical or reverse splitting of S2 may be heard and seen in cases of left bundle branch block. The left bundle branch, this is the branch of the bundle of His, the AV bundle, which is responsible for the depolarization of the left ventricle. So when there is left bundle branch block, it would take longer time for the left ventricle to get depolarized, and hence left ventricular systole would be delayed, and accordingly the aortic valve would close after the pulmonary valve, resulting in paradoxical or reverse splitting of S2 heard during expiration. Paradoxical splitting is also heard and seen when there is prolonged left ventricular systole, as in cases of aortic stenosis or severe hypertension or left-sided congestive heart failure. So here we have the phonocardiogram of aortic stenosis. So in mild aortic stenosis, still the split of S2 is physiological during inspiration, with the aortic valve closing before the pulmonary valve. But in moderate and severe aortic stenosis, the splitting becomes paradoxical because left ventricular systole is prolonged as a result of the narrowing of the aortic valve orifice. Paradoxical splitting is also heard if there is early onset of right ventricular systole, like in cases of Wolff-Parkinson-White syndrome. This is a syndrome where there is an accessory pathway between the right atrium and the right ventricle called the bundle of Kent, and it is through this bundle of Kent that the cardiac impulses pass directly from the right atrium to the right ventricle, bypassing the atrioventricular node, hence resulting in early onset of right ventricular depolarization and early onset of right ventricular systole. So in this case, the right ventricular systole would end before left ventricular systole, resulting in earlier closure of the pulmonary valve and paradoxical splitting of S2. So we have finished with the detailed description of S1 and S2, and let's describe S3 and S4. S3, the third hard sound, is heard about 1/3 the way through diastole in children and many normal young individuals. So we may still hear S3 with the stethoscope in children and many normal young individuals when diastole is about 1/3 through. This coincides with the period of the rapid filling phase, and exactly S3 might be heard during the transition between the rapid and the slow filling phases of ventricular diastole. It is probably due to the vibrations which are associated with the inrush of blood from the atria into the ventricles during ventricular diastole. It is a soft, hard sound. Its frequency is low, so it is a low-pitched sound with a duration of approximately 0.05 of a second, and best heard at the apex of the heart. So it is best heard at the mitral area. The fourth hard sound can be heard before the first hard sound, and it is detected by phonocardiography before it can be detected by phonocardiography before the first hard sound, and it is caused by the oscillations of the ventricles of the ventricular walls as a result of atrial systole, as a result of atrial contraction. So it is recorded by phonocardiography during atrial systole. It is usually not audible with the stethoscope because its pitch is very low. It has got a duration of approximately 0.04 of a second. It might be heard with the stethoscope in elderly subjects at the apex of the heart at the mitral area. So, why do we auscultate the heart and listen for the first hard sound and the second hard sound in particular? This is important for the diagnosis of abnormal heart sounds. The abnormal heart sounds are known as the heart murmurs or the cardiac murmurs. So, sounds or noise can be produced in the heart normally as a result of closure of the valves, as we mentioned in the previous slides. Closure of the AV valves produces S1 at the beginning of ventricular systole, and closure of the semilunar valves, the aortic valve and the pulmonary valve, produces S2 just after the end of ventricular systole and at the beginning of ventricular diastole. When there is increased intracardiac hemodynamics, we might also hear S3 and S4 with the stethoscope, and also detected with phonocardiography. So they can be heard in normal subjects. Intracardiac, when there is increased intracardiac hemodynamics, this might result in abnormal heart sounds. And again, these abnormal heart sounds are known as the heart murmurs or the cardiac murmurs, which can be heard when there is increased blood flow across normal valves, or when there is turbulent blood flow through an abnormal valve, or when there is turbulent blood flow through a septal defect. So what are the causes of these murmurs then? Murmurs can be innocent, And these innocent murmurs are common in children and young adults. And murmurs can be also physiological. And the physiological murmurs are heard when there is increased blood flow across normal valves, as in cases of pregnancy, hyperthyroidism, anemia, fever, and also in children. In cases of hyperthyroidism and anemia and fever, there is hyperdynamic circulatory state. So there is an increase in the intracardiac hyperdynamics. Murmurs can be pathological, and pathological murmurs are associated with turbulent blood flow through abnormal valves or through septal defects. And these abnormal valves or septal defects could be congenital or acquired. The most common abnormalities of the cardiac valves are in the form of stenosis or narrowing of the valvular orifice, and in stenosis the valve doesn't open properly when it is supposed to open. Valvular abnormalities can be in the form of valvular insufficiency. And in valvular insufficiency, the valve fails to close completely when it is supposed to close. And when this happens, the valve would leak, resulting in backflow of the blood across the incompetent or across the insufficient valve. Valvular insufficiency is also known as valvular regurgitation or valvular incompetency. We might have, in some patients, we might have a combination of valvular stenosis and valvular insufficiency. We describe the abnormal heart sounds, the cardiac murmurs. Remember again, the murmurs could be innocent or physiological. We describe the murmurs based on their timing in the cardiac cycle and based on their shape, location, radiation, the intensity, the loudness of the murmur, the frequency, the pitch of the murmur, and how the sound of the murmur looks like. This is the quality of the murmur. Based on the timing of the heart murmurs in the cardiac cycle, murmurs could be classified into systolic murmurs, which are heard during ventricular systole. So they are heard between S1 and S2 because the time interval between the first heart sound and the second heart sound coincides with ventricular systole. Systolic murmurs are further subclassified into early systolic murmurs, mid-systolic murmurs, which are also known as ejection systolic murmurs. ESM means ejection systolic murmurs. And we have late systolic murmurs and band systolic or holosystolic murmurs, where the murmur extends throughout the entire ventricular systole. Murmurs could be diastolic murmurs when they are heard during ventricular diastole. So diastolic murmurs are heard during the time interval between S2 and the subsequent S1, because this time duration signifies and coincides with ventricular diastole. Diastolic murmurs are further subclassified into early diastolic murmurs, mid-diastolic murmurs in mid-diastole, and late diastolic murmurs. The murmur, the heart murmur, can extend throughout systole and throughout diastole. And when this is the case, the murmur is classified as a continuous murmur. Based on the shape of the heart murmurs, the murmurs are classified into crescendo murmurs with increasing loudness, with increasing intensity, decrescendo or decrescendo murmurs with decreasing loudness, with decreasing intensity, and crescendo decrescendo or crescendo decrescendo diamond. These are the crescendo decrescendo, the diamond shaped murmurs with increasing and then immediate decrease in loudness and intensity of the murmur. And we also have plateau or uniform murmurs, where the intensity of the murmur is uniform throughout the murmur, whether it is systolic or diastolic. But in this phonocardiographic recording of the murmurs, since the murmurs are detected between S1 and S2, so these are systolic murmurs. The location of the maximum intensity of the heart murmurs is determined by the site where the murmur originates. So the murmur can be best heard at the aortic or pulmonary or tricuspid or the mitral auscultatory areas. The murmur might radiate, and radiation of the heart murmurs reflects the intensity of the murmur and the direction of blood flow. Of course, murmurs with high intensity are more likely to radiate, are more likely to be heard. Radiation means that they can be heard at other areas in the body. For example, the murmur of aortic stenosis radiates to the neck. The murmur of mitral regurgitation radiates to the axilla, as we will describe in the subsequent slides. Based on the intensity, the loudness of the heart murmurs, murmurs are graded on a 6-point Levine scale. So we have 6 grades: grade 1, which is also referred to as grade 1 over 6, grade 2, which is grade 2 over 6, grade 3, which is grade 3 over 6, and so on. Obviously, grade 6 over 6 murmur is the murmur which has got the greatest intensity. So here we have again the grades of the classification of the heart murmurs based on their intensity. So grade 1 or grade 1 over 6 murmurs, these are soft murmurs which are heard only in quiet surroundings. Grade 2 over 6 murmurs, these are murmurs which are louder than grade 1 murmurs, and grade 2 over 6 murmurs are soft murmurs which can be heard in noisy surroundings. Grade 3 murmurs are prominently heard murmurs. Grade 4 over 6 murmurs are loud murmurs which are associated with a thrill. A thrill is a slight palpable vibration which is felt by the hand over the chest wall. Grade 5 over 6 murmurs are loud murmurs which are heard with the edge of the stethoscope tilted against the chest wall, and they are associated also with thrills, because grade 5 murmurs are even louder than grade 4 murmurs. Grade 6 or grade 6 over 6 murmurs, these are the murmurs which have got the highest intensity, so they are loud murmurs which can be heard even with the stethoscope 5 to 10 millimeters away from the chest wall, and obviously they are associated with thrill. So grades from 4 to 6 are associated with a thrill, palpable, which is a palpable vibration, and this palpable vibration is felt with the hand placed over the chest wall. The frequency of the murmur, the pitch of the murmur, can be high, medium, or low. The quality of the murmur can be blowing or harsh, or the murmur can be rumbling or musical. There are other characteristics or criteria which we use to describe the heart murmurs. For example, variation of the intensity of the murmur with respiration. Murmurs which increase in intensity with expiration are more likely to originate from the left side of the heart as a result of aortic or mitral valve disease, while murmurs increasing in intensity with inspiration originate with tricuspid or pulmonary valvular stenosis or incompetencies. Murmurs might show variation with the position of the patient and variation with special maneuvers. For example, the Valsalva maneuver. The Valsalva maneuver, this is forced expiration with closed glottis or closed nares. And you might have heard of this Valsalva maneuver in the respiratory block. The Valsalva maneuver decreases the intensity and the duration of most murmurs. So having finished with how we describe the cardiac murmurs, let's very briefly describe the pathophysiology of the systolic murmurs. So we will now start describing some important systolic murmurs, and then we will describe some important diastolic murmurs, and at the end of the lecture we will describe a continuous murmur. Systolic murmurs are heard when there is harsh and increased turbulence in blood flow during the period of ventricular systole. So they might be associated with increased blood flow across a normal valve, and these are the physiological systolic murmurs. And the systolic murmurs can be also associated with increased flow into a dilated great vessel, or an increased blood flow across a narrowed ventricular outflow tract, or stenosis of the aortic valve or the pulmonary valve. Or they might be associated with increased blood flow across an incompetent atrioventricular valve. So in cases of mitral regurgitation and tricuspid regurgitation, systolic murmurs are heard. Systolic murmurs, so these are pathological now murmurs. Systolic murmurs can also be associated with increased blood flow across a ventricular septal defect. So we shall now describe the mid-systolic murmurs, which are also known as the ejection systolic murmurs, ESM. These ejection systolic murmurs, the mid-systolic murmurs, are the most common kind of heart murmurs, and they usually have a crescendo-decrescendo profile. The crescendo-decrescendo profile with increasing loudness, and the loudness immediately decreases. The mid-systolic, the ejection systolic murmurs can be innocent in children and young adults, physiological as a result of increased intracardiac hemodynamics, as in cases of anemia, pregnancy, fever, and hyperthyroidism, where there is hyperdynamic circulatory state resulting in increased intracardiac hemodynamics with increased blood flow through normal valves. The mid-systolic, the ejection systolic murmurs could be pathological, secondary to structural cardiovascular abnormality, as in cases of aortic stenosis, pulmonary stenosis, hypertrophic cardiomyopathy, and mitral valve prolapse. We will describe the hemodynamics and the murmur of aortic stenosis in details. In aortic stenosis, there is narrowing of the aortic outflow tract. And this narrowing of the aortic outflow tract, it causes obstruction of the flow of the blood from the left ventricle into the ascending aorta during the ejection phase of the cardiac cycle. This gives rise to a mid-systolic murmur, to an ejection systolic murmur, which is heard between S1 and S2 with a crescendo, decrescendo profile. The murmur of aortic stenosis is best heard at the aortic area, and it radiates along the carotid arteries in the neck. It is an ejection systolic murmur of crescendo-decrescendo contour with a gap between the end of the audible abnormal sound and S2. So the murmur of aortic stenosis, it sounds like lop-sh-dop, lop-sh-dop. Now, the lop is the first hard sound, the dop is the second hard sound, and sh, this is the crescendo, decrescendo, the crescendo, decrescendo ejection systolic murmur of aortic stenosis. It is harsh, loud, and might be associated with a thrill. Aortic stenosis might be associated with the pathology of aortic stenosis. Aortic stenosis might be associated with older age as a result of the wear and the tear processes which take place in the aortic valve in elderly subjects. And aortic stenosis might be also caused by when the aortic valve has two clasps, and rheumatic fever might also result in stenosis of the aortic valve as a result of scarring of the aortic valve, as in children and young adults. Let's now describe the hemodynamics of aortic stenosis. We mentioned that in aortic stenosis there is narrowing of the aortic valve orifice. This narrowing of the aortic valve orifice increases the resistance of the aortic valve. So during ventricular systole, the left ventricle should work harder in order to overcome the increased resistance of the aortic valve and eject the stroke volume. However, the ejected stroke volume, who is obviously lower than in normal subjects with normal aortic valve. As a result of this, as a result of the work of the left ventricle, the harder work of the left ventricle to overcome the increased resistance of the aortic valve, ventricular systolic pressure increases, and this is, here we have, this is the left ventricular pressure curve showing a left ventricular systolic pressure of 210 millimeters of mercury, which is much higher than normal. The normal left ventricular systolic pressure is 120 millimeters of mercury. So as a result of aortic stenosis and the increased resistance of the aortic valve and the harder work of the left ventricle to overcome the increased resistance of the aortic valve, a pressure gradient is detected between the left ventricle and the aorta when the stenotic aortic valve is open during the ejection phases of the cardiac cycle. So this is the gradient which is detected during ejection. This is the aortic pressure curve with a systolic aortic pressure lower than normal because less stroke volume is ejected into the aorta when there is aortic stenosis. In this panel, the aortic valve orifice is normal. There is no narrowing of the aortic valve orifice, and when the aortic valve opens during ventricular ejection, the left ventricle and the aorta behave as if they were one chamber, and now in normal conditions during ventricular ejection, the left ventricular systolic pressure and the aortic systolic pressure would be the same 120 millimeters of mercury. Because in aortic stenosis the left ventricle works much harder to overcome the increased resistance of the stenotic aortic valvular orifice, aortic stenosis might result in concentric hypertrophy of the left ventricle. The pressure gradient which is detected between the left ventricle and the aorta during ventricular ejection is also seen in this diagram. So here the left ventricular systolic pressure is about 150 millimeters of mercury, is less than what we have seen in the subsequent slide, because the pressure gradient which develops between the left ventricle and the aorta, it depends on the severity of aortic stenosis. Anyway, the aortic systolic pressure is approximately 90 millimeters of mercury, which is much lower than the normal 120 millimeters of mercury aortic systolic pressure. In cases of moderate to severe aortic stenosis, the second heart sound is reversibly split. We might hear reversed splitting of the second heart sound, and we have described the reversed splitting of the second heart sound in aortic stenosis in the previous slides, because in aortic stenosis the period of left ventricular systole is prolonged, so it would take longer time for the left ventricle trying to overcome the increased resistance of the stenotic aortic valve, and hence the aortic valve would close after the pulmonary valve, resulting in reverse splitting of S2, which is heard during expiration. We will describe now another systolic murmur, which is the murmur of mitral valve prolapse. In mitral valve prolapse, there is bulging of one or both of the leaflets of the mitral valve into the left atrium during left ventricular systole. This causes mid to late systolic murmur, which is best heard at the apex And the murmur of mitral valve prolapse is characterized by a mid-systolic click. So this is the mid-systolic click of the murmur of mitral valve prolapse. So the abnormal sound itself, the murmur, is heard after the click. The murmur of mitral valve prolapse changes with the position of the patient. Here we have, this is the murmur when the subject is in the supine position. This is when the subject is standing, and here when the subject is squatting. You need not to worry about all these details. All what you need to know is that mitral valve prolapse gives a mid to late systolic murmur, best heard at the apex. Mitral valve prolapse might be seen in about 5% of normal people, and it might be asymptomatic, and in some subjects it might be associated with sudden death. In cases of mitral or tricuspid regurgitation or ventricular septal defect, the increased turbulence of blood flow results in pansystolic murmurs. The pansystolic murmurs are pathological murmurs. They begin immediately with S1 and they continue up to S2. So the murmur extends all the way through systole. We will describe the murmur and the hemodynamics of mitral regurgitation in more details. So an incompetent and insufficient mitral valve is an insufficient mitral valve is when the valve doesn't close probably when it is supposed to close. The mitral valve is supposed to be closed at the beginning of systole in order to prevent backflow of the blood from the left ventricle into the left atrium. So an incompetent mitral valve, an insufficient mitral valve allows blood to regurgitate from the left ventricle into the left atrium throughout ventricular systole. And as a result of this, left atrial volume and pressure are increased during left ventricular systole. On the other hand, left ventricular volume and pressures are increased during diastole. How this happens? Because during diastole of the left atrium and also during the diastole of the right atrium, but let's focus on the diastole of the left atrium, blood continues to flow from the pulmonary circulation and blood accumulates into the left atrium. Remember, in the first lecture we mentioned that the left atrium serves as a receptacle and a blood reservoir for the left ventricle. So blood accumulates in the left atrium during diastole. During the before the mitral valve opens. Before the mitral valve opens. Now, when the left ventricle begins to contract at the beginning of ventricular systole, the mitral valve is supposed to be closed. But the mitral valve doesn't close properly because it is an incompetent valve. It is an insufficient valve. So now, during ventricular systole, blood regurgitates from the left ventricle into the left atrium, and this regurgitant blood is added to the blood which is already accumulated in the left atrium. So during subsequent left ventricular diastole, then the left ventricular volume and pressures are increased. However, there is no pressure gradient between the left atrium and the left ventricle. The incompetent mitral valve and the retrograde flow of the blood from the left ventricle into the left atrium during ventricular systole results in a pansystolic, a holosystolic murmur, which is heard all the way through systole. The sound of the mitral regurgitation murmur is of reasonably constant intensity throughout the ejection period. So the murmur of mitral regurgitation sounds like lupshdub, lupshdub. It is best heard at the apex and it radiates to the axilla. It is a soft, high-pitched blowing murmur. Pathologically, mitral regurgitation might be associated with mitral valve prolapse, mitral valve myxomatous degeneration, or myocardial infarction, or rheumatic heart disease, cardiomyopathy, and also endocarditis might result in mitral regurgitation. So here we have the left ventricular pressure curve, which is normal, and this is the left atrial pressure curve showing a tall V wave. Remember, the normal V wave in the atrial pressure curve is because of the accumulation of the blood into the atrium. Again, to this accumulated blood into the atrium, when the regurgitant blood is added, this gives a tall V wave, as we have just described when we described the hemodynamics of mitral regurgitation. Finally, the ventricular septal defect, when there is a defect in the interventricular septum, also the murmur is a pansystolic or a holosystolic murmur. So here we have phonocardiographic recordings of the important systolic murmurs. So this is the ejection systolic murmur, the mid-systolic murmur of aortic stenosis, the ejection systolic murmur of pulmonary stenosis, the mid to late systolic murmur of mitral valve prolapse, the holosystolic murmur of mitral regurgitation, the hollow or the pansystolic murmur of tricuspid regurgitation, and again in cases of ventricular septal defect, the murmur is pansystolic or holosystolic. The murmur of aortic stenosis sounds like look stop, look stop. So the murmur is diamond shaped. It has a crescendo decrescendo profile, whereas in the pansystolic murmurs of mitral regurgitation, tricuspid regurgitation, and the ventricular septal defect, the intensity of the murmur is almost uniform all through systole. So it sounds like the murmur of mitral regurgitation sounds like lupshdub, lupshdub. Now we shall be describing some important diastolic murmurs, and unlike systolic murmurs, which could be innocent and could be also physiological, diastolic murmurs are almost always pathological. So they almost always indicate heart disease. And there are two basic types of diastolic murmurs: early decrescendo diastolic murmurs. And the early decrescendo diastolic murmurs signify regurgitation of blood through an incompetent semilunar valve, and thus these early decrescendo diastolic murmurs might be heard in cases of aortic incompetency or pulmonary incompetency. The second basic type of diastolic murmurs is the rumbling mid or late diastolic murmurs. The rumbling or the mid to late diastolic murmur signifies stenosis of an atrioventricular valve. So the rumbling mid or late diastolic murmur is heard in cases of mitral stenosis or tricuspid stenosis. We shall now describe the hemodynamics and the murmur of aortic regurgitation. So the incompetent aortic valve doesn't close probably when it is supposed to close. The aortic valve should be closed at the beginning of diastole to prevent backflow of the blood from the aorta into the left ventricle. However, in cases of aortic regurgitation, the valve is incompetent. And as a result of incompetency of the aortic valve, there is retrograde flow of the blood from the aorta into the left ventricle during ventricular diastole. The amount of the blood which regurgitates from the aorta into the left ventricle during diastole might be as much as 60 to 70% of the ejected stroke volume. As a result of that, the diastolic aortic pressure decreases, but the systolic and left ventricular pressures, the systolic pressure in the aorta and the systolic pressure in the left ventricle increases. How does this happen? Now, when there is aortic valvular incompetency, blood regurgitates from the aorta into the left ventricle during diastole. And during diastole, the left ventricle is also receiving blood from the left atrium. So now, the regurgitant blood from the aorta into the left ventricle is added to the diastolic filling volume of the left ventricle from the left atrium. So this would result into more filling of the left ventricle during diastole, and as a result of this, during the subsequent systole, the left ventricle would eject larger stroke volume, resulting in an increase in the aortic systolic pressure. So the aortic systolic pressure is increased and the aortic diastolic pressure is lowered in cases of aortic regurgitation, and as a result of this, the pulse pressure is increased, because the pulse pressure is the difference between the systolic pressure and the diastolic pressure. The murmur of aortic regurgitation is an early diastolic decrescendo murmur, which is best heard at the second to fourth left intercostal spaces, with the patient sitting up, leaning forward at the end of expiration. It is a left-sided murmur, and remember, left-sided murmurs increase in intensity during expiration. And the murmur of aortic regurgitation is a regurgitant murmur, so blood regurgitates from the aorta back into the left ventricle, and it is because of that the murmur is best heard at the second to the fourth left intercostal space, while the murmur of aortic stenosis is best heard at the aortic area, which is at the second to the third right intercostal spaces. The murmur of aortic regurgitation is high-pitched, loud, blowing murmur. It has got a decrescendo profile, so it wanes with time as the aortic pressure falls. And pathologically, aortic regurgitation might be associated with aortic root degeneration. It might be also associated with rheumatic heart disease, ventricular septal defect, and prolapse of the aortic valve in kids. The murmur of aortic regurgitation, it is an early diastolic decrescendo murmur. Again, I'm describing the murmur, and it sounds like lob, lob. Lob is the first hard sound, dub is the second. This is the decrescendo blowing murmur of aortic regurgitation. We shall now be describing the murmur of mitral stenosis. When there is narrowing of the mitral valve orifice, the narrowed mitral, this is a normal mitral valve and this is a narrowed mitral valve orifice. The narrowed mitral valve orifice results in impairment of the emptying of the left atrium into the left ventricle during ventricular diastole. So as a result of this, left atrial pressure greatly exceeds left ventricular pressure when the stenotic mitral valve is open during left ventricular diastole, during the filling phase of the left ventricular diastole. It is because of that a pressure gradient is detected between the left atrium and the left ventricle during the filling phase of left ventricular diastole when the stenotic valve is open. So here we have, this is the diastolic left ventricular pressure, and this is the diastolic left atrial pressure. The diastolic left atrial pressure is increased as a result of impairment of the emptying of the left atrium into the left ventricle. The left ventricular pressure is normal, but the left atrial pressure has increased. In fact, the pressure and the volume can be dramatically elevated in the left atrium. However, in most cases of mitral stenosis, left atrial pressure and also the aortic pressure curves are normal. Narrowing of the mitral valve orifice and impairment of emptying of the left atrium into the left ventricle during left ventricular diastole results in a diastolic rumbling murmur. The murmur is often heard with an opening snap. So this is an opening snap, and this gives the murmur a decrescendo, and slightly crescendo profile. So the murmur begins early after the opening snap. So its timing in the cardiac cycle is mid-diastolic to pre-systolic murmur. The murmur, it sounds like this: lob, lob, to brrr, lob, 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 dob, lob, dob, to brrr, lob. So it is a rumbling murmur which is heard immediately after the opening snap. It is best heard at the apex, and very interestingly, it is a low-pitched murmur. It has got a low frequency, and that's why we use the bill of the stethoscope to listen to the murmur of mitral stenosis. Mitral stenosis pathologically might be associated with rheumatic fever. So we finished with the description of the important diastolic murmurs, and here we have the phonocardiographic recording of these important diastolic murmurs. So this is the early diastolic decrescendo murmur of aortic regurgitation. This is again the early diastolic decrescendo murmur of pulmonary regurgitation. This is the mid-diastolic to early systolic murmur of mitral stenosis, the rumbling murmur. This is the opening snap. Lastly, let's describe the continuous murmur of patent ductus arteriosus. In the fetal circulation, there is a connection between the pulmonary artery and the aorta. This vascular connection is known as the ductus arteriosus. which is very important to the fetal circulation. This ductus arteriosus should close very shortly after birth. And when it doesn't close after birth, the condition is termed patent ductus arteriosus, and this is associated with a continuous murmur, which is heard all the way through systole and diastole, and it is best heard at the upper left sternal border, and its quality is it is a machinery murmur. It is a machine-like murmur, and cases of patent ductus arteriosus might be also associated with left to right shunt and cyanosis, which is bluish discoloration of the skin and the mucous membrane. So here we have a patent ductus arteriosus between the aorta and the pulmonary trunk, and this is the continuous machine-like murmur of the patent ductus arteriosus, heard throughout systole and diastole. It is heard throughout systole. This is S1 and S2, so this is systole. This is S2 and the subsequent S1, so this is diastole. And that's the end of this lecture. And here we have the intended learning outcomes again. And thank you very much for listening.